Good afternoon, everyone. Um, this is a very important topic, which I'm going to speak for next 20 minutes and with some demonstration. And even if I'm able to establish the importance of this topic in anyone present in this hall and all the steps required for the basic and advanced life support, then definitely we will be able to save lots of life. So just starting with the topic is systematic approach to an emergency patient. Now, what is the requirement of the systematic approach? Whenever we have an acutely ill or injured patient, we need to give a very systematic approach for optimal care. What is the goal? What is the goal of this systematic approach? The goal is that we have to support and restore the oxygenation, ventilation, circulation, and with the intact neurological outcome in any patient. Now, what should be the actions for the systematic approach? The actions are divided into 3 important steps: BLS assessment, that is basic life support assessment, primary assessment, and secondary assessment. Now, these are the 3 actions which we have to take. But how do we approach to these 3 actions? Whenever we have a patient, emergency patient with us, the first thing, the emergency can happen anywhere. It can happen in hospital. It can happen anywhere outside hospital. So the first thing which we need to do is to establish the scene safety. So many people sitting out here, we can face an emergency even in a house which has caught fire, or maybe on the middle of the road. So we have to give emergency care, but first thing we have to do, establish a scene safety. So once we have established the scene safety, the next important step is that we have to have an initial impression of the patient, whether our patient is a conscious or an unconscious patient. If the patient is unconscious, then the steps would start with BLS assessment, that is basic life support assessment, followed by primary assessment, followed by secondary assessment. And if the patient impression is conscious, patient is talking or telling his problem, then we will not go with BLS assessment. We will go with primary assessment followed by secondary assessment. So let us start with the first case scenario. The patient is unconscious. So what do we do in this scenario? As I told in my last slide, we start with basic life support, BLS assessment. Okay. So what is the first step whenever we face an unconscious patient? We alert the emergency medical system. Remember everyone, you cannot carry out a BLS to the patient alone. You cannot give BLS, basic life support, to a patient alone for a long time. So you need to call for the help, and you should ask for automated external defibrillator and a manual resuscitator. So I will just show you the manual resuscitator. This is the automated external defibrillator. You can see this is automated external defibrillator, and that is manual. Show the manual resuscitator, and that is manual resuscitator. In BLS training, you need to be familiar with these 2 equipments. Well, remember one thing for sure, that for BLS training, you don't need to have a very advanced knowledge of medical system or medical equipments or anything. But these 2 equipments, automated external defibrillator and a manual resuscitator, would be very helpful to give a BLS support to any patient. So I have called for help. Now what I will do, I will check for the carotid pulse and the breathing of the patient. So as you can see, whenever we face a patient who is unconscious, we check the carotid pulse in an adult, and then we see the breathing. We see the carotid pulse and we see the breathing. As you can see, my colleague is showing you how to feel for the carotid pulse, and her eyes is on the chest of the patient to assess the breathing of the patient. So these 2 things, the pulse assessment and the breathing, would establish whether the patient is in cardiac arrest or not. If pulse is present with no breathing, there could be 3 scenarios, guys. There could be 3 scenarios. If pulse and breathing, the carotid pulse and breathing, both are there, then the patient is not in cardiac arrest. Then what do? We wait for the ambulance to come. If pulse is present, she could feel the carotid pulse, but there is no movement of the chest. That means there is no breathing. So patient is not in cardiac arrest. Patient is in respiratory arrest. In this case, my colleague will show you how to open the airway and give a rescue breath. Show how to open the airway and give the rescue breath. You can see this image. You can see this image. This is the way. You just show how to open the airway. Don't use the manual resuscitator. You can see in this image, there are two maneuvers: jaw thrust and head tilt and chin lift. By these two maneuvers, we are opening the airway of the patient and giving the rescue breath. So how she will give the rescue breath? She will just take one normal tidal volume breath and attach to the oral cavity and the nose of the patient, and she will give the breath. Okay? Or, so this is how we give if the carotid pulse is there, but there is no breathing. And the third scenario is both pulse and the breathing is absent. So patient is in cardiac arrest. This is cardiac arrest. So we will start with high quality chest compression. So just see this flow chart. This is American Heart Association BLS flow chart. And when a person is in cardiac arrest, come on this part of the flow chart. This is when the person is in cardiac arrest. We start with high quality chest compression. So my colleague will demonstrate how to do high quality chest compression. Okay, show. So what she has done, she has taken one hand on the lower part of the sternum, and as you can see, her elbow is straight, and she has interlocked her other hand on the hand present on the chest of the patient. And now, by her entire weight on the chest of the patient, she is compressing. So this is how. And you can just watch that when she is compressing, she's allowing a complete recoil. She's allowing a complete recoil. So, okay, stop. So what are the 5 points of high quality chest compression? Chest compression should be at the rate of 100 to 120 compression per minute. Compress at least 5 centimeter. The depth should be at least 5 centimeter. Allow a complete chest recoil. Avoid excessive ventilation. We should never give excessive ventilation because that will further compromise the cardiac output by compromising the venous return of the patient. And we should switch the compressor about every 2 minutes. Remember, when one person is compressing the chest for a longer time, then the quality of compression would definitely suffer. So one should switch the compressor every 2 minutes if possible, if there is more than one person present. Okay, so these are the 5 points for high quality chest compression. And guys, very important, if I am doing 5 high quality chest compression, we are maintaining 30% of the cardiac output. And if I am not doing high quality chest compression, I am not even maintaining that 30%. So it would not be a useful compression. So we have to do a high quality chest compression. Okay, so what I'm trying to tell you that there is three important intervention in basic life support. Number 1, high quality chest compression. Number 2, followed by as you can see, this is right? So you just have to turn it on, attach the pads, it will start giving you commands, and it will give the shock once you press the shock button. Okay? Here, as you can see in this BLS, you need not know how to analyze the rhythm. You need not know intervention like have to do compression and attach. These are the 3 important points. The critical you can save someone's life. Compression. In the breath. We are attaching defibrillator. We are checking the pulse. All these should be done as fast as possible within 10 seconds of AED, automatic external defibrillator. Well, there is no monitor attached to it. So you don't have to know anything about the rhythm. You don't have to know knowledge. But when you attach a manual resuscitator, an ECG, and then you see it on the screen, different rhythms, you have to recognize these codes. The first one is ventricular fibrillation, which is just a wave from around our baseline. Then ventricular tachycardia, that is a monomorphic ventricular tachycardia, polymorphic possible, that is wide QRS complex, no PJs, only QRS complex. ACE would be a straight line, and pulseless electrical activity would be no pulse and any ECG strip, but there would be no pulse. We call it pulseless electrical activity. So these are the four rhythms. Now management will be dependent upon what type of rhythm. Ventricular fibrillation and ventricular tachycardia, they are managed in the same way. Three interventions in these two rhythms. Shock. These are shockable rhythm, as I already told you. These are shockable rhythm. So you have to give shock as soon as possible, guys. Good enough to convert into a mechanical output. So what do? We give shock and we stop the heart. And when the heart resumes its normal action, we pray that it should take the sinus rhythm, because the normal activity of heart, is the sinus rhythm. So we stop the heart and we pray that heart should resume the sinus rhythm. That's why we give shock. So we should give shock as soon as possible. The other two intervention, as you can see in this flow chart, is that we should put an IV line and give injection adrenaline. Adrenaline, 1 milligram, 1 in 10,000, and repeat it after every 3 to 5 minutes. Why do we give adrenaline? To maintain the perfusion by maintaining a vasoconstriction. And we can use one more drug, amiodarone. That is an anti-arrhythmic. We give 2 doses of amiodarone, one after another, 300 milligram followed by 150 milligram bolus. And no other intervention. We give shock every 2 minutes after CPR. If the rhythm is shockable, that is VF and pulseless ventricular tachycardia. We give injection adrenaline every 3 to 5 minutes. And we can give amiodarone for 2 doses, 300 milligram and 150 milligram. No other intervention for managing VF and pulseless ventricular tachycardia. And remember, guys, you can save the life if you recognize these two rhythms and give shock as early as possible. Studies have shown that if the time interval between shock delivery and the VF, the cardiac arrest, is minimal, chances of ROS, that is return of spontaneous circulation, is best. Okay. Then the other two rhythm is our asystole and pulseless electrical activity. These are non-shockable rhythm. Remember, in asystole, there is no movement of the heart. And in pulseless electrical activity, there is an electrical activity, but there is no mechanical output because there is no pulse. The reason may be that heart is empty. That is, there is no blood in the heart. So if you give shock, it would be of no benefit. So what you have to do, you have to find the cause, treat the cause, and then only the cardiac arrest would be reversed. So in these two types of rhythm, the only thing you have to do, you have to give chest compression, CPR, and you have to give injection adrenaline every 3 to 5 minutes. Repeat it every 3 to 5 minutes. No shock, no amiodarone, right? No antiarrhythmic. So this is the only intervention, and try to find the cause. So this is how we manage asystole and pulseless electrical activity. So this is how we approach a patient who is unconscious and in cardiac arrest. Now let us say scenario 2, patient is conscious. Then we will not go for BLS. We would immediately go for primary assessment followed by secondary assessment. So primary assessment, the primary assessment stands for ABCDE: airway, breathing, circulation, disability, and exposure. So in a conscious patient who is not in cardiac arrest, we have to look the airway of the patient, whether the airway is patent or not. If airway is not patent, we do a simple airway maneuver like head tilt and chin lift and try to maintain the patency of the airway. If patient's airway is not, we are not able to maintain the patency, we can use the advanced airway device. We have to confirm whether we have put the advanced airway device properly or not. For that, we have so many other devices like capnography. And if required, we should put the endotracheal tube. Then the second thing we have to do is see the breathing, whether the patient's ventilation and oxygenation is adequate or not. Well, patient may require a positive pressure ventilation, right? So we need to support the ventilation in that case, or patient may require only a mask, oxygen mask to be attached to him. So we try to maintain the oxygenation of the patient between 90 to 94%. And in cardiac arrest patient, we always give 100% oxygen. But for other patients who are not in cardiac arrest, we give enough oxygen to maintain the oxygenation between 90 to 94%. It is not necessary always to give everyone 100% oxygen. Remember, oxygen is a double-edged sword. It is vital, it is required, but it can be toxic as well. So always give enough oxygen to maintain oxygenation between 90 to 94% in a conscious patient requiring a support for airway and breathing. But in a cardiac arrest, always 100% oxygen. Okay, then we see the circulation. If patient is in cardiac arrest, the circulation is assessed. How we are maintaining the circulation in cardiac arrest? By chest compression. So we have to see that our chest compression should be effective. Then we have to recognize the rhythm of the cardiac arrest. We have to manage accordingly whether defibrillation is required or not. We have to put IV line. We have to see what type of rhythm patient has. If patient is a conscious patient, whether it is a tachyarrhythmia or bradyarrhythmia, we have to recognize the rhythm and manage accordingly. And we have to give those medications which would convert those rhythm in a sinus rhythm, right? So we have to manage the circulation accordingly. Then disability. We have to see the neurological status of the patient. AVPU, a very simple way to assess the neurological status. Whether the person is alert or whether the person is responding to the voice, verbal command, or responding to pain, or patient is simply unresponsive. So we call it AVPU. Exposure. Once we have done ABCD, right, ABCD, then we definitely have to see about exposure as well. Why? Because if we will not expose the patient completely and see if we expose the patient, definitely we can have an idea of etiology, why the patient has gone into cardiac arrest. Maybe a trauma patient bleeding from some site, maybe from fracture, maybe patient is in, let's say, cardiac tamponade case. If we'll expose and auscultate the patient, we can try to find the etiology by exposing the patient and assessing the patient accordingly. So this is ABCDE, the primary assessment. Then comes secondary assessment. The secondary assessment is the assessment done to find the cause of the current status of the patient. Why the patient has gone into cardiac arrest or why the patient is in acute emergency, right? And the secondary assessment can be done easily by remembering few things. First, we have to take a very focused history. If patient is not unconscious and patient can give the history, we'll take it from patient. And if patient is in cardiac arrest, we will take it from the attendant or the person who has brought the patient. And we will have a focus history because we have to gather a lot of information in a very small time period. And a mnemonic sample helps us in taking that focused history. Sample S stands for sign and symptoms. What is the present sign and symptoms? If the patient is conscious, patient is dyspneic, patient is in unstable chest pain, patient complaining chest is not being maintained. So signs and symptoms, okay? Then we have to take a quick history of any allergy of the patient. Any medications patient takes, patient may be on diuretic, possibility of potassium sparing diuretic, and hyperkalemia. We'll think about hyperkalemia and is the cause of current condition of the patient. We will look the past medical history. Patient was a patient of cardiac problem, and maybe patient is in acute coronary syndrome. Maybe patient is having acute ischemia, and because of a big ischemia, patient is in current clinical condition. So we'll take a very fast medical we'll take a very fast past medical history. Then we'll just have a history about when the patient had his last meal, because we have to see whether the patient will aspirate or not in present condition. And event, the event which put the patient in the current scenario, the series of event which had put the patient in the current scenario. So this sample would help us. Now, apart from sample in the secondary assessment, we have to remember about 5H and 5Ts of cardiac arrest or acute emergency. 5H and 5Ts of cardiac arrest or acute emergency. So what is 5H and 5Ts? H stands for, the 5H stands for hypoxia, hypovolemia, acidosis, hypothermia, hypokalemia. So very quickly, we will rule out these 5 causes which could have led the patient in current clinical condition or which has led the patient into cardiac arrest. So we'll rule out these 5 conditions. Then 5 Ts would be tension pneumothorax, cardiac tamponade, pulmonary thrombosis, coronary thrombosis, and toxin. So we'll rule out these 5 conditions also. That is any of these conditions responsible for the current clinical status of the patient? Because guys, as soon as possible, we find the cause, the chances of restoring the ventilation and circulation of the patient would be fastest. And there would be a chance to revert the patient. Now, one thing I want to tell you, that all these we can do by our simple investigations like ABG, which you read in the last session, which you understood in the last session, like CBC, ABG, and simple by auscultation, palpitation of the patient, etc. Clinical examination. Now, one very good advanced equipment which we have, which is helping us nowadays, and which has become like stethoscope for intensivist in ICU, and that is our ultrasound machine. If someone is in acute emergency or is in cardiac arrest, this bedside ultrasonography would help us in many ways. This could help us in diagnosing pulmonary embolism. This could help us in diagnosing pericardial tamponade, and this could help us in diagnosing a lot of other tension pneumothorax, etc. Remember, guys, whether it is pulmonary thrombosis or pericardial tamponade, or it is tension pneumothorax, these conditions causing cardiac arrest, if we will not do a definitive management of these conditions, it would be very difficult to reverse the patient from cardiac arrest. So we need to find the cause. And bedside ultrasonography, simple, effective equipment in helping us to do. If we don't have a proper training in bedside ultrasonography, not a big deal. By simple clinical examination, by simple auscultation, by simple investigation, we can try to find the cause. So this is how we do a systematic assessment of a patient in acute emergency, whether in cardiac arrest or not in cardiac arrest. Okay. So, so thank you so much for your patient listening. Any question? You're most welcome. Yeah, please go ahead.
Mic. You can ask from the mic.
For male and female? Pregnant?
Yeah, there I mic.
Ma'am, are there any changes in the AHA guidelines for any pregnant female if ANC patient comes and we have to give CPCR? So
Okay.
there might be few difference. So what
There
is that?
are definitely, thank you so much. There are definitely differences in managing a cardiac arrest in a pregnant lady compared to a normal patient. See, in a pregnant lady, most of the steps are same, but there are few important things which we need to be focused on. In a pregnant lady, after 20 weeks of gestation, there is what we need to do. We need to lift the uterus away from the major vessels. So we have to do a left uterine displacement, right? Left uterine displacement. And the very important thing which you asked was there any modification in this latest guideline of AHA? See, previously the AHA used to say that you just do a by a left up, you do a left uterine displacement. But nowadays AHA says keep the patient supine and do a manual displacement so that patient remain in a supine position for a better chest compression. If you will tilt the patient for the uterine displacement, the chest compression would not be efficient. So keep the patient supine, do a manual displacement, and then give chest compression. Chest compression, the site, the steps, the rate, everything is same, 100 to 120, everything. The other important thing in a pregnant lady is that when you put the IV line, intravenous cannula for managing the patient, try to put it above diaphragm, right? Again, because of the pressure of gravid uterus on the major vessel. So try to keep it in the above the diaphragm. The third important thing is that if you're unable to resuscitate a pregnant lady within 4 to 5 minutes, then do a perimortem cesarean section. Take the baby out, because even if the baby is not viable, because the mother is priority. And if you will separate the baby, the chances of resuscitation would be better. And one more very important thing, pregnant ladies, young patients, they are young patients and they give ample time before going into cardiac arrest. So try to try not to land these patients in cardiac arrest. Try to prevent the condition which is producing cardiac arrest, whether the lady is in hypoxia or she's having let's say hypovolemia, anything. Manage that and try to prevent her landing in cardiac arrest. Try to do a pre-assessment carefully in these patients. Okay, any other question? So you can come here.
Thank you, Dr. Swati, for excellent talk, excellent deliberation, excellent